Thank you for the opportunity to speak today. My name is Marincowitz. I'm an NIHR clinical lecturer in emergency medicine. This means I'm an A&E registrar 50% of the time and do research at the University of Sheffield the other 50%. I am conducting a project assessing reasons for variation in hospital transfer of care home residents as part of the Yorkshire and Humber Arc. The UK population is rapidly ageing, with over 20% of the population projected to be aged 65 or over by 2030. Although only a small proportion of people aged over 65 are care home residents, they account for a disproportionate number of emergency department attendances and inpatient admissions. Around half of the care home population have a significant degree of frailty, and 2/3 have some degree of cognitive impairment. The average life expectancy of care home residents in the UK is 24 months in care homes without nursing and 12 months for care homes with nursing care. So why do we want to reduce hospitalizations of care home residents? Well, firstly, there are established associated risks, including hospital-acquired infection and reduced function. Transfers can also be distressing and increase the risk of worsening confusion on the background of existing cognitive impairment. Work by the Health Foundation found that up to 40% of hospitalizations could be avoided and were for conditions that may have been treatable in the community. However, once hospitalized, care home residents are more likely to undergo investigations than other older adults. Such emergency inpatient treatment is costly compared to other models of care. Although the majority, 70 to 80% of deaths of residents occur in care homes, 40% of residents have at least one inpatient admission in their last month of life. Existing research has found up to 8-fold variation in rates of hospitalizations between different care homes. Some commentators have proposed the use of continuous monitoring of rates of emergency admission or place of death of care home residents as potential care home quality indicators. As the first part of the work I'm conducting with the Yorkshire and Humber Arc, we completed 2 systematic reviews. The first ended up as a synthesis of existing research and qualitative reviews exploring the experiences of residents, family and care home staff of decisions to transfer residents to the emergency department and factors which influence these decisions. The second was a more straightforward systematic review identifying factors which were associated with likelihood of resident transfer to the emergency department. I'm not going to go into a lot of detail or depth about our review methods here, but we conducted the reviews in accordance with Enterex and Prisma guidelines. We additionally searched multiple electronic databases and grey literature. The qualitative component included 6 previous reviews and 2 accompanying full reports. The quantitative component included 26 primary studies. We identified 3 common important themes in our review exploring experiences of transfer decisions. The first was that transfer decisions involved multiple stakeholders, including residents, family members, care home and clinical staff, and there is a hierarchy within these decision makers. Family members' wishes were often prioritised. Residents could feel excluded from decisions. Care home staff felt they needed to negotiate or control information in order to achieve the outcome they thought was needed. Despite their important role in the hierarchy, family members could feel uncomfortable making decisions, especially regarding end-of-life care, leading to uncertainty in hospitalizations as a default. Some hospitalizations were made reassuringly with the positive intent of improving outcomes for residents. These were characterized as being resident dominant by Aaron's et al. Some conditions, such as broken bones, were always thought to need assessment in hospital. However, unfortunately, some hospitalizations occurred due to factors external to the resident with no expectation of improving resident outcomes. These were characterized as being resident subordinate by Aaron's et al. Such external factors could include perceptions of high staff workloads in the facility leading to unsafe care or being unable to access community services to support treatment in the care home. A strong recurring theme was the fear of medico-legal consequences staff had in not transferring acutely unwell residents, especially when advanced care planning was not robust or where communication with family members was difficult. This is a shortened summary of the results from our quantitative review. We found 7 common domains which were associated with likelihood of transfer to the emergency department. These were demographics, comorbidities, frailty, medication use, permanently indwelling devices such as urinary catheters, presence of advanced directives, and care home level factors. Importantly, there was no simple relationship between increasing age and frailty and likelihood of transfer, with both younger and the oldest, most frail residents being less likely to be transferred. Specific conditions like heart failure and COPD and polypharmacy were all associated with increased likelihood of transfer and may be potential targets for interventions. There was also a clear relationship between services available at care home and quality rating and likelihood of transfer. Reducing avoidable hospitalisations has clear benefits for both the NHS and, importantly, residents themselves. However, transfer decisions are complex. They involve multiple stakeholders and occur within the context of individual care homes and the health system in which the care home exists. Decisions to transfer may be less dependent on the nature of the acute deterioration of the resident and more about communication between stakeholders, especially family members, and robustness of advanced planning. Our quantitative review has identified potentially modifiable risk factors to avoid admission and information regarding factors which may need to be adjusted for if continuous monitoring of hospitalisations from the care home is used as a quality indicator. In our future and related research, we are using routine data to estimate variation in rates of transfer between care homes in Yorkshire and the Humber. We're updating a systematic review of interventions to reduce hospitalisations from care homes. In the future, I'm working up a grant proposal to model and better understand reasons for variation in hospitalisations between care homes in Yorkshire and the Humber in order to recommend tailored interventions for care homes with high rates of transfer. Thank you for listening, and I look forward to catching up with you at the conference.